Hello, everyone. This is Eric Glazer. You are watching Bright Spots in Healthcare live recording of our podcast. You're behind the scenes with my illustrious panel. We're about to go live in front of a Zoom audience in just a moment. Bear with us. All right, let's do this. Everyone ready? Have fun. This will be fun. Hello, everyone, and welcome. This is Eric Glazer, and welcome to your Bright Spots in Healthcare live recording of the podcast. Today's topic we're covering is health equity and social determinants of health, incorporating data and performance measures. If you have not joined us before, each and every episode, we bring together leaders from the industry to identify and share with you bright spots, success stories that they're having at their organizations. Our goal each and every episode is to share as many bright spots as possible at health plans, health provider organizations, and other healthcare related organizations across this country so that we can inspire your thinking and hope that maybe you could take some of the ideas shared on our show and bring them to your organization. We believe that this strategy of finding a bright spot and cloning it is the most effective way of improving healthcare in our lifetime. We have an abundance of riches for you today. Our only challenge is we only have 60 minutes to bring it to you. This is probably a 3-hour show. We've done our best to organize all the best bright spots and get them to you on time. To save time, we're going to post a link in the chat. My producer, Sherry Keels, is going to do that in a moment, that provides you with the bios of this incredible group, that you can get a sense of the expertise that you are going to benefit from in just a moment. We are also going to introduce each individual when they come on for their first question. That will save us some time as well. All right, let's get started. So, first of all, we're able to bring you this show each and every week, usually each and every week, because first of the great support we get from all of you to either subscribe to the podcast, and if you haven't subscribed to the podcast, Bright Spots in Healthcare, wherever you consume your podcast, and listen to the show when you come on live for a live recording like this kind of format. For those of you who have come in via Zoom, that really helps. And the feedback you provide us on the feedback form that we're going to send to you in about 45 minutes past the hour to allow us to pick the topics that are most interesting to you. Those are all things that are incredibly important. But that allows us to bring in thought leaders from corporations that want to support the show. And we are really pleased to announce that the latest partner and sponsor in the Bright Spots in Healthcare family is an organization called Evolent Health Services, which I'm sure many of you have heard about. They combine people and a platform to improve healthcare administration by making it more autonomous and less error prone. And I'm going to tell you a little bit more about them later on in the show, but you could check them out right now at evolenthealthservices.com. Okay, let's get started. I'm going to bring on first RJ Briscione. He is the Senior Director of Social Determinants and Health Strategy and Execution at Aetna, a CVS health company. And let's start with positive deviance, RJ. I know CVS, I like to think that CVS Aetna leaders are listening to the show regularly, Bright Spots in Healthcare, because if those bright spots is another word for positive deviance, it's what the show is based upon. And I would love for you to share with all of us a little bit about how your organization is applying positive deviance or bright spots to your healthcare equity strategy.
Yeah, thanks, Eric. Thanks for having me. First of all, great to be here. Really appreciate the time. So yeah, I think this came from a conversation that we were talking about how we use the social analytics, which I think we have time set up for that later. So I won't go deep into that, but the discussion always lends itself to like, oh, let's find the gaps, or let's find where we can't get, where there's not places to bring members to the kind of community services that they need in the community. But the positive deviance theory, and I'll have to give credit to some of my colleagues for introducing me to it, and for much smarter people for coming up with the terminology. But is something, as I studied it a little bit, that absolutely resonated with me, because it's really the base of all we've done in my career at Aetna Medicaid. And then further into looking into social determinants, and the positive deviance theory says, I think this is super important, that the communities have the wisdom, the power, and the resources. Sometimes we have to help them with the resources a little bit to solve their own problems, right? It's pretty profound. We're sort of flipping the problem. Instead of like bringing the problem, like we're going to come solve all your problems, we recognize that the communities and especially the community-based organizations, which we'll talk about some opportunities with community-based organizations a little bit later, are the problem solvers, and they have the ability to solve those problems. So we can use some of the data that we're getting, this very new, very impressive data, to go and say, like, where are the good spots? Where are the bright spots for you, Eric? Where is the positive, and how do we help them with resources? How do we get our members to where those opportunities are? So that's the role in that theory, the role of what they call the expert outsider, or the interventionist, which is what we are in these cases, is to go to the people, start with what they know, and they've most likely done it, and that's always been the case. In Medicaid especially, we really like to get out into the communities, and when you sit down with these community organizations, you can see that they almost always have the answers, and they know the answers. They may actually need some help with some of those resources, right? Literally every community I've ever been in has people that have already solved that problem. And if you think about the people that they're solving the problem for, they're solving it with the highest odds, right? The highest odds against them, probably without extra resources. So that's kind of the bigger theory picture. And I think, going to this and using this data, and we'll touch on it a little bit now, we'll get to it a little bit more later. It enables us to both get that individual level, which has been the thing that we've been missing so far, so we can match members, patients individually to their social and to their health needs. But it also enables us to talk about the communities that we either work in or that we're looking to work in, and talk to states about that in a way that the states, who are procuring these Medicaid beds, may not even know the level of detail that we can get to and talk about in the community, and then problem solve with that.
Do you have an example of what are these deviants that you could point to, and how that's kind of influenced a strategy or an approach to a program?
Yeah, I mean, I might use this example a second time, or a slightly different example later on. But our work in South Florida with Feeding South Florida, the food bank there, right? We looked at the data, and we looked at where there are, kind of the traditional look for food deserts, but also we're able to look at individual level patient data, member data, and find members with food insecurity, and also with a health condition, a higher A1C than that we wanted to go after. But we're matching that with that positive that Feeding South Florida can bring to that, by being very mobile and very nimble, and then bringing biweekly food interventions to our clinic partners. So we're doing it originally, our first pass at this was doing these much larger distributions, where it was, frankly, the food was heavy and it was difficult to get. People were having difficulty bringing it out. We're doing smaller, more frequent, in more places and more local, with that on the ground partner that has the knowledge there.
I'm going to bring in Katie McKillen. She's the regional president and market operations at Evolent Health. And Katie, can you let's share how health plans are creating, sort of building upon what RJ just said, that they're built. How can health plans create a more scalable approach to reducing health disparities at that community level? Maybe provide an example of how a health plan is taking this approach and how they're building that foundation.
Yeah, thanks, Eric, and thanks for having us on. I'd say where we see health plans successfully creating scalable approaches, building on what RJ said, they're able to create a bridge between the health plans and the communities served by first, starting with the foundation of where the members are geographically and prioritizing disproportionately impacted areas. And second, really mapping out the key stakeholders within that community that have trust of the members. And then finally, kind of understanding the barriers that the members face. So, as an example, we worked with a large Medicaid health plan in Chicago early on in the pandemic, and we started listening to the needs of the community. And we connected with aldermen, commissioners, faith-based leaders, key community groups, in addition to our members virtually. And as COVID progressed, it was clear both nationally and in Chicago, there was a disproportionate impact to the Black and Latinx communities. And we'd heard additional concerns around vaccine hesitancy in these communities. So we developed a vaccine education campaign with the intent to really support the promotion of the vaccine and address the myths and misinformation that contributed to vaccine resistance in the Black and Latinx communities. And the way we created a scalable approach around this was we recorded 8 videos where some of the most influential faith leaders, pastors, priests, and more from the prioritized geographic areas in Cook County got on and they talked about their own personal hesitancy and how they overcame it. And it became a personal story. And so those 8 videos were actually cascaded down to 500 churches and shared at Easter Sunday services. And we're expected to reach over 1 million members that were attending in-person or online services. So really just building on what RJ said, the actual skills and the resources are in the community, and with a little bit of help and maybe a little bit of resources, you're able to really support, a large number of members.
So let's stay local and let's continue to focus on local. And I'm bringing Amy Riegel. She's the Senior Director of Housing at CareSource. Amy, how are you using data to design programs and outreach to members that are the most impacted by disparity?
Yes. So at CareSource, one of the things you find with a health plan is that there is a lot of data out there. And in some cases, we might actually feel like there's too much data. And so it's thinking about how we take the claims data that we have, the membership data, layer in other data sources that are bringing in socioeconomic information, and keep that at a level that's easy to then design program outreach with. And as we take that, knowing how to layer on hyper local data sources, especially that are pinpointing disparities. So in Columbus, Ohio, we have a program called Healthy Beginnings at Home that started in 2018 that reached out to homeless women or women who were experiencing severe housing instability, who were pregnant and who lived in areas that were at high risk for infant mortality, to provide rental assistance and housing stabilization services to see if that helped to improve their birth outcomes. And in that outreach, what we had to do was not only take that claims data that we had that showed that the women had a notification of pregnancy and find that notification of pregnancy as quickly as possible, and then wrap in their socioeconomic. But we also used data from the Kirwan Institute at The Ohio State University that had really been able to zero in on the neighborhoods with the highest levels of infant mortality in the region. And using that mapping data, we were able to prioritize the women from those neighborhoods, centralize our outreach to those neighborhoods. Once again, just like Katie said, go to the places that were trusted within those neighborhoods to be able to tell people about the programs. Oftentimes you can put out flyers, you can do mailers, you can even do maybe a text campaign or something like that. But the greatest source is word of mouth and the community understanding the intervention and being able to tell others about it and build that level of trust. And being able to get hyperlocal, not only were we able to reach the women that we intended, but we were also able to capture the racial demographics. So the research study ended up being 81% Black women. And that was because we used such a specifically targeted way of doing outreach into the community.
So let's stay in Columbus, Ohio. It's a little bit of a coincidence, and talk about from a provider perspective, a unique bright spot. So Nick Jones is the director of the Healthy Neighborhood, Healthy Families program out of Nationwide Children's Hospital. Nick, can you tell us at a high level what this program is all about?
Yeah, sure. Thanks, Eric, and thanks to Brightspot for inviting us in to this panel, and always good to be on a conversation with Amy, proud partner of CareSource, especially in our housing work. So Healthy Neighborhoods, Healthy Families is Nationwide Children's Hospital's investment to get outside of our walls and really be proximate to our neighbors in the south side of Columbus and the Linden neighborhoods. Those are both downtown adjacent neighborhoods that have experienced years of disinvestment and ongoing gentrification. So with the housing first approach, we also invest in interventions focused on economic development, education, wellness, and community enrichment. And we know the impact that social determinants of health have on overall health outcomes, as we've already heard in today's conversation. And so that's why our board and senior leadership about 15 years ago really encouraged us to get more proximate, and you'll hear me use that word a lot, but get more proximate to the community and really understanding what's happening literally across the street from this world-renowned healthcare institution that is Nationwide Children's. And so we really focused on addressing issues like the infant mortality disparity ratio, high unemployment, housing insecurity, and low rates of kindergarten readiness that were some of the worst outcomes, not just in our city, but in our state. And so when we're looking at the pillars of prevention as defined by the CDC, we know that total population and community-wide prevention can have the biggest impact on overall community health. And HNHF, as we call Healthy Neighborhoods, Healthy Families, HNHF really takes this approach by partnering with local CBOs, schools, civic associations, and area commissions, city and county governments, community foundations, but most importantly, community residents. Those are leaders in this work. You know, we say every day, when I was in the office, before COVID, I was driving out of the neighborhood to my own neighborhood. And so the real leaders of this work and the sustainers of this work are our community residents and partners in that space. All of our work is measured through a framework called Pediatric Vital Signs, which really focuses on 8 population health measures that we know are important.
Hey, Nick, we're losing you.
For overall health outcomes to invest in. So just, do you hear me?
I hear you now.
You hear me?
Yeah, I do. Go ahead.
Oh, sorry. Just a few quick examples of some programs that we have to offer through our work in Healthy Neighborhoods, Healthy Families. Specifically in our housing space, we have a rental program that CareSource is a great supporter of and really try to provide affordable rental housing to residents in our community. A home repair program that works with existing homeowners to ensure that they can stay in their homes as their property values rise and the impact on the quality of housing changes, as well as a new home ownership opportunity for families in our community. In economic development, we focus on free tax preparation services, job readiness skills, working with local businesses to support them in growing their work in the community. And so overall, we really take a holistic approach to addressing population health and social determinants of health, and really is partnership driven, but most importantly, looking at our neighborhood residents and the real leaders in this work as we go forward. I'm going to stop so I don't cut out again here and fix that.
I'm going to come back to you later on and try to get a little bit of a roadmap if people want to build a similar program. Katie, I want to come back to you. I just want to take one question from the Q&A module. By the way, folks, there's a Q&A module by now. Everyone's been using Zoom for quite some time. You know where it is. That's how we look at the questions. Please don't use chat for that. I just want a quick follow-up to your answer, Katie. Do you know how many people change their minds after watching those video programs? Is there any measurement?
Yeah, I mean, it's a great question. I think one of the things that we've worked on doing internally is trending by race, vaccine status, both initial and fully vaccinated individuals. And I think at least what we can say is we continue to see trends in the right direction. The unfortunate piece is I feel like we don't necessarily have a case control study for this because ideally we have as many people as possible actually getting the vaccine. So the way that we're able to at least see positive outcomes right now is continued positive trends. I think now we're getting to a little bit more of a plateau across COVID vaccination rates, but at least throughout the time that we did it, we definitely at least heard qualitative stories as well of people that did change their mind based on the information that they heard from their pastors, their priests, the people that they trust and they listen to every day.
Real quick, folks. So I mentioned the feedback form. It comes to you at the 45-minute mark. We look at every single answer. It drives our programming. We're really value the hour you spend with us each and every week, whether you're listening live or whether you're in your car right now or walking and listening to the podcast. We want to make sure the hour is well spent. And so we pay attention to everything you say and produce the content that you need. To that end, on April 14th, we're going to do another live recording at the same time of day, 12 p.m. East Coast time. And it's entitled Your Social Determinants of Health Roadmap, Integrating Social Care and Healthcare. Very related to this topic, of course. It's almost going to be an extension of this conversation. And so if you want us to register you for that now, of course, it's free and not have to go through the registration process again. Our producer is going to put up a poll. And if you put up yes, we'll just automatically register you for April 14th, which will be a live recording via Zoom. So just let us know. Let's move on and let's, someone recently said to me, very recently, the future of health is social. And so how are healthcare organizations right now coming together, these competing health plans coming together in a region or nationally to drive better social health? And for that, I'm going to start with bringing in Merrill Friedman. She is the Regional Vice President of Inclusive Policy and Advocacy at Anthem.
Great. Thanks, Eric. Can you hear me okay?
Yeah.
Wonderful. I appreciate the opportunity to be here. I love the conversation thus far. And I think, part of answering this question is where people have, my esteemed colleagues here have really talked so much about community and trust, right? And that's why this partnership is so important of health plans coming together and partnering with and helping to support the community-based organizations, because that's where the magic happens. And RJ is going to weigh in on my comments here with me as well. He is one of our partners, but this was a really unique opportunity, we thought, to come together and really build a partnership that aligns social care, that ties it to health outcomes for people. And we work really hard right throughout all of our social drivers of health conversations to not over medicalize people's lives, but where you work, play, live, eat, sleep, right? Do all the, great things that you do in your home and community really impacts your health outcomes. So we want to be able to be that partner and help bridge that gap so that community-based organizations can get reimbursed for the services that they provide for people, right? It's another way to advance equity is to allow for, representation and diversity across our community organizations that are supporting people who live in their communities. So we developed with, obviously, Aetna, Humana, United, Health and Human Services, the Administration for Community Living, Partners in Care Foundation, this partnership, right, that brings plans together to truly align, to enable successful collaboration between healthcare, community care networks, right, coming together and creating efficient and sustainable ecosystems that we need to make sure that people, families, communities have access to holistic, person-centered social care that is delivered with demonstrated cultural humility. And that's equity across the board, diversity across the board, people with disabilities, people identify as LGBTQ, people of color, right? We want to get and make sure that everybody accesses services in their communities where they are comfortable and where they have trust. So we bring together this group of diverse stakeholders, shared vision, and look to create that sustainable community-centered social care delivery system for everybody that's empowered by the information we get from communities that was referenced earlier as well. And creating this sort of shared governance model for financing, multi-stakeholder accountability, and federal, state, local policy levels. So that's where we go. We have several work groups within this. So RJ, I'm about to bump it over to you in a minute. That's your heads up, right? We have a couple of work groups that are all working towards this shared goal as well, with lots of stakeholder engagement. Core competencies and an approach to qualifying CBO networks, encouraging broad use of existing and proposed billing codes streamlining our contracting process for simplicity between health systems, payers, community-based organizations, common IT security and interoperability standards, and making sure that organizations have these financing strategies for sustainability. And that's really the impetus for it, is everybody's involved in this. People in the communities, health systems, federal partners, state partners. RJ, what would you add to that?
Before RJ jumps in, I have two questions, one from me and one from an audience member. So first of all, the name of the program, so if everyone got it correctly, is called Partnership to Align Social Care. Is that correct? Just want to clarify. And is there a website to check this plate or no? There is.
There is a website. There's not a lot on the website yet. There is I'll probably find it when I'm not talking, but there's a little, there's a short press, not short, but there's an informative press release from the organization that talks about it. We've started with some funding, both from Albert Wood Johnson and from a couple of the participants. So it outlines the goals and mission there.
I've got it right here, RJ. So I'll
yeah.
I have one other question from RJ, and maybe you could tackle this or bring it.
Merrill. Yeah.
So when working with community partners, how are you reimbursing them for their time, their ideas, any work investment they have to put in?
Do you want me to go? And I'll let Merrill, because it's probably, this is part of the point. This is actually a great question, right? So part of the point is, like, Merrill and I are going to have two different answers. Katie's probably going to have a third answer. Amy's probably going to have a fourth answer on how we're doing that, right? The answer is it depends, and it's not clean and it's not easy. And that's the point of the partnership, right? And the point of the partnership is not to make it one national structure that every community-based organization from Miami to Seattle has to follow, right? The point is that it's really about putting those community-based organizations really more in the driver's seat, so that they're able to create, and it doesn't have to be exactly this, but a good concept that we're starting from is for them to be able to create what's called network lead entities, where the community-based organizations, those that are some of the larger ones, so your larger AAA is the Partners in Care Foundation, who's helped start this, as a great example. They're already doing something very, very similar to this and can lend their expertise. They can coordinate smaller, maybe less technically advantaged CBOs into an organization where there then is a payment structure, right? And so we will have model contracts. We'll have tenets and principles that will be in all of the contracts, but it's really to put those CBOs in the driver's seat. So, I mean, right now you could ask all of us, and it's all on a case-by-case basis. And there's tremendous opportunity for the CBOs in this world, for us, all of us, to come together and help find that. Tim McNeil, who's one of our leaders of this, likes to talk about the blending and braiding, right? There's a lot of revenue streams out there available that maybe people are picking up on piecemeal here and there combined, and some of them are left on the table. And if we can make a really nice dent in that and blend and braid those streams to get to the community-based organizations for social services that affect health, and we can measure both the social outcome and the health outcome, which are core to having to do this, because somebody else is going to ask, if they haven't already, how are you measuring it?
Yeah, how are you? I mean, how are you measuring?
Right. So, so how we're measuring the social things we're doing now is case by case. It depends on, so the example I gave earlier is we're measuring the hopeful decrease or change in food security, and the change in A1C that's specifically set up for that. We'll come together and come up with some of the measures that we want to affect, right? And each entity may come up with a different measure.
Great. Anything like
that? It'll be standardized. It'll be on a contract. It'll be, something that everybody's agreed upon, and it'll be a real contract with either a payer or an entity on the payer side, or on, and it's not just for payers. We have large hospital systems already involved, right? It'll be for the health entity that wants the contract for those community, for those social services.
Any bow you want to tie on that, Merrill, or before I move on?
I'll add one. So I'll add one thing, and so we had this discussion. Some of you, some of our hardcore SDOH nerds may have heard Merrill and I just a few days ago at the Rise SDOH conference speak about this very topic. Among others, we had our CBO and other NHHS colleagues on there actually as well, right? And so I think the realization is the one of the big ways we got to this is that I think we're all equally guilty of this. We saw big, impressive technology, both externally to our organizations and within our organizations, come in and say, we can solve these social needs, right? And yeah, they're very much a part. All of that technology has to be very much a part of this solution, but it can't be the only part of the solution, right? I've said this going way back, and I wish I would have trademarked it or something, but it has to be tech plus touch, right? So every solution for these kinds of members, these kinds of patients, has to be tech plus touch. So I'm going to go back to my favorite example, Eric. I used this in the presentation the other day, but in that Feeding South Florida work in Miami, there's 4 different clinics. They might as well be nearly in 4 different countries. And I'll give you the example why. One of the clinics, every patient there speaks Haitian Creole, right? So the point of the clinic is to come in, get the members' A1C checked, ask them check on their food security for the remaining 2 weeks, and then they get to go shopping on the Feeding South Florida mobile food pharmacy truck, which it looks like a little mini grocery store. We have pictures of it. And so they're talking with the registered dietitian that's there, walking them through their food choices, which is almost all fresh fruit, produce, including proteins. So really excellent shopping experience, right? But we have to solve on the ground for every single one of them being native Haitian Creole and either having very low or no English. And there's no technology that I know of, and no technology coming anytime soon that would solve for that in a dignified way that will support that member and encourage them to come back. So I mean, that's a kind of a classic example there where we have, our Aetna folks on the ground, because it is Miami, because it's from the community they come from, do speak Haitian Creole.
Great. Okay, I'm gonna move us on. I'd mentioned.
So Eric,
oh,
did you?
Go ahead, Merrill.
No, sorry. We can tie it up later. It's good. We can move on.
Yeah, Merrill was supposed to tie it up, and then I just jumped in.
I'm sorry,
Yeah.
my bad.
No,
I'll blame
it's
RJ. I'm going to blame RJ for just throwing me off.
That's always
I blame RJ for everything. This is fine. No, I think he really covered so much of it, but it's tech plus touch. This is a business of people. We have to lead with people, right? We have to lead with trust. And so tech supports that, right? Tech helps to facilitate it, but we've got to lead people with people. And I think that's just where we're trying to find the best way to go about that. And that happens in community. And not everybody trusts, right? Historically marginalized communities or populations or people do not necessarily trust technology. Some older adults don't trust technology, right? So we want to use that to support people's access and to collect data and to make sure we're eliminating harmful bias, right, in AI and other areas. But, again, back to that trust. And we joke about this the other day, like, you talk to your son-in-law about, getting a flannel shirt for Christmas. The next thing you know, you've got ads on Facebook around your flannel shirts, right? People, right? We have to go where people trust, so people actually access the services, right, that are culturally relevant and related to their health, or we're not going to win. And the win is people's health and well-being across communities. So I think we can wrap it there.
That's a nice bow. All right, I want to move on to using data to enhance programs. But before we do, I mentioned at the top of the show that we have this great new partner to the program in Evolent Health Services. And I'm gonna play off this tech first touch theme that sort of RJ has built for us here, because Evolent Health Services, EHS, they're disrupting healthcare administration and generating for organizations exceptional clinical efficacy and better risk adjustment while simplifying the overall administration process. And similar to what Tesla did for automobiles and what Amazon did with retail, EHS is helping transform our healthcare industry from antiquated to innovative. And they're doing it through tech and touch. They have the industry's only true to end-to-end integration platform, and they're combining it with touch. The smartest people in the business knowing how to operate that solution for and with every type of health plan or risk-bearing provider organization. I've gotten to know them now in the production of this show and some of the future things we're going to be doing together. And I encourage you to reach out to Katie or some of their other leaders and just pick their brain because they've got a lot of intel. They're at evolenthealthservices.com. If you want an introduction to any of their leadership, email me personally. And during the feedback form, if you just want to get an introduction to Katie, you could click on a button in that feedback form, and I will personally introduce you to Katie via email so you can have a warm introduction. All right, let's move to using data to improve future interventions. And I want to bring in A.B. Riegel back from CareSource to talk a little bit about that.
Yes, so I think it's so funny because we all do kind of just roll right into one another, and so much of it just builds on what the last person has said. And so I want to go back to that example of healthy beginnings at home. And so when we started that program in 2018, we started reporting out on some of the data about the women who enrolled in the program. It was a randomized controlled study, so we collected a lot of information to make sure that the two groups were very similar in characteristics. But we also collected a lot of data about the women who applied for the program but didn't get accepted. And perhaps they weren't accepted because of various reasons that prohibited them. But why weren't women getting accepted? And what were the characteristics of that group? And how could we really think about how the women had been tracked for high levels of disparities, and yet they still weren't able to access this intervention? And I said at that time, like, if nothing else, at least we have this information that we can take from this program. Now, fortunately and unfortunately, the program yielded significant health outcome results where we did see that the babies in the intervention group were more likely to be full-term healthy birth weight, significant reductions in NICU utilization, and we also saw significant reductions in the per member per month costs across the whole entire household. And it's important that when you get those great results, you don't sit there and say, well, this is the perfect intervention, let's just go out and replicate it as is. What we did is we went back to the women and we said, what worked? What didn't work? What was abrasive to you? What would have been better in this situation? And we also took the information from the women who didn't get into the program. How could we have lifted some of those barriers so those women could have participated? Or is there another intervention that's necessary for those who are left out? So now as we are looking at replication, we have those focus groups that we conducted. We have feedback forms from all the women who participated. And as we go on to replicate, we're creating an advisory board for the cross-site replication in Ohio. And on that board, there will be women with lived experience who either participated in the first round or who faced homelessness during their pregnancy. And those women will be compensated for their participation on the board, but they will also be matched with a community mentor to help them pre every meeting, post every meeting, to answer any questions, to be their trusted advisor. So when maybe they don't understand a term that's being used and none of the rest of us are raising our hands saying we don't understand, even though maybe we don't understand either, they have someone that they can turn to and ask those questions or help them prepare for the meetings. So all of that to say, as we think about these interventions, they have to be optimized, just as we would optimize any other benefit within our health plans or any other service that a doctor is providing. Social determinants of health is the same, and we have to be having that optimization and continuous improvement process. And we have to admit when we're wrong and when we're falling short and when we need to step up and do a little bit better, because that's where we're really going to get to the systemic change, which is our goal all the time in SDOH.
Well said. RJ, I didn't know if you wanted to build upon that as it relates to how you guys approach social analytics, or was it covered there?
Yeah, I mean, it's mostly covered there. Maybe maybe quickly, what we're doing is, and I touched on this earlier, is for the first time, at least for us, is really getting that individualized social risk score, right? And then matching that individual social risk score for each member. And for those that have one or more high needs and say they have food and housing and security high needs, right? Then we're creating an outreach for them to try to direct them to some of the referral services that we have. So we have, depending on the state, we have both Unite Us and Aunt Bertha now Find Help, right? And that's the beginning of that. And so I think, the question was asked, I think on one of the panels I was on earlier this week, what's the future? The future is we have to build, here's where the technology really comes in, that we need to be able to build those automations. That's a very manual process. It took us a long time to build that right now because we're jamming some stuff together. As we're wont to do in healthcare technology, right? But as we can automate more of that and get those outreaches flagged for both the human touch, the care managers, and the referral opportunities. So, for example, Unite Us now has built in some humans in the middle that really help direct those members to the right resources. I think that's the golden opportunity in using these social analytics. So we're doing that with Socially Determined right now. Our teams are hard at work, as you might guess, building our own kind of social analytic engine for the future.
So that's great. Socially Determined, another one of our partners. So Katie, what if you don't have the right data? Like what does a health plan do if they want to leverage social determinants, say, to reduce disparities in health, but they don't have enough comprehensive demographic and social data?
Mm-hmm.
What do they do?
Yeah, I mean, historically, most of our Medicaid health plans have largely been dependent on the state as the source of truth for demographic data, and it's not as comprehensive as we'd like to be able to drive the best member engagement and care. And, similar to what Merrill was saying, the billing codes that would typically represent social determinants of health needs are not widely adopted yet. So one of the things that we've done, at least in late 2020, early 2021, as the pandemic continued to kind of highlight the magnitude of disparities, we worked with our Medicaid health plans to develop a racial disparity and healthcare disparity dashboard. And the focus of this was really to change the way we were stratifying data in our executive level dashboard. So we published a dashboard that's stratified by race and ethnicity to compare quality metrics, engagement metrics, satisfaction data, utilization metrics. So really thinking about, everything from PCP visits to HRA completion rates, care management engagement rates, CAHPS surveys. And then we complemented this with a parallel view to stratify by geography. And with the stratification of these, we were able to identify meaningful differences both from a process metrics and an outcomes metrics perspective. And it highlighted a few things, not all that were surprising, but when presented in a way that is specifically measured and has the right visibility at the executive level, you're able to identify meaningful differences where you can get the commitment to change that you need. So, a lot of what we saw pretty clearly immediately was just there are clear disparities in risk and utilization. And previously, I think there's been hesitancy in sharing some of those differences. The second big thing that we saw was there were significant gaps in disclosure of race information that we received from the state. So 36% of our membership is currently coming through with not provided race. And the last part of this is when we're actually trying to leverage our claims data, which is typically the way that we are getting communication from providers around diagnosis codes. Only about 2% of our members have, the Z codes or the social determinant of health related ICD-10 codes that would be able to identify high risk. So you have to look for other ways to be able to identify that information. And all that said, what this dashboard really reiterated was the need for comprehensive data and allowed us to move away from the idea that no data, no problem is not okay. We have to move to taking action to actually supplement the data. And so the process that we're going through now is really identifying the key attributes for appropriate care and where do we need to stratify those. So thinking about, what NCQA is doing around health equity standards and the OMB standard categories right now, from language, gender identity to sexual orientation, where do those need to be applied? And then, for the other, race, ethnicity gaps that we have today, we're working on mapping out all of our member touch points, from call center touch points, care management touch points, HL7 data that we get from hospitals, text vendor data, to figure out where can we supplement the data. And a part of this is really setting the foundation for how do you ask. Most of the people that have ever had to ask for demographic data in the past have been asking for confirmation of their address, their actual address, their phone number. But in what situations should we be actually asking for race or ethnicity data, and giving them the right scripting to start with why? Why are we asking for it? And that's kind of, a lot of the work that we're doing right now. But the last piece of this is actually trying to collaborate with a lot of the other MCOs for improved processes to get the right data from the state, have the right abilities to get batch updates of demographic data to the state, both, upon the initial application that we're receiving, but also streamlined way that these are often very transient members that we need to continue to be able to update member demographic data with the state. And there's not necessarily easy ways to do that right now.
Does that overall approach, when we're thinking about the work that goes into that, does that have some residual value as we think about the overall process for redetermination, which we're going to go through an unprecedented time that's new to us around redetermination, as we're potentially coming close, I don't want to jinx us, but towards the end of the peak of this pandemic, where we're going to have our health plans. Will this health plans in that overall process, which I'm sure is good, a lot of people on this call are worrying about?
Yeah, and I mean, I think you said it really well. Like, the magnitude of this redetermination effort that we're about to embark on could not be understated, of the importance and the importance of doing it right. So a lot of what we've talked about today has been around, technology and data plus that human touch. So, I think when we're thinking about redetermination today, it's starting with data and thinking about a multimodal approach for our members. How are we outreaching to make sure that we've got the right demographic data? In what situations have we actually seen members that have gaps in care before, that we can predict that they're probably the ones that are moving frequently, and they might need that human touch. They might need a true phone call that goes out to them to confirm where are they living, where should we send sometimes paper forms that are coming from the state. And, I think the other part of this is like having the technology in place where any member that calls into a customer service center needs to have a redetermination date front and center on the member record, so that that customer service rep is able to speak to it right away. So it's starting with the foundation of members, both from a member perspective as well as a provider perspective, giving that the PCPs, their impaneled members, and the respective redetermination dates, giving them the analytics of how do they compare for actually retaining their members against some of the other providers, and then expanding that to the full care team. What's the role of pharmacy? Is there any messages that they can actually give from a fill perspective as a member is picking up their prescription? What's the role of care management? And then, there's going to be situations that people really are not eligible anymore, and we need to actually help coordinate what is the appropriate next continuity of coverage for them.
So in our due diligence as we're preparing for this show, we came across a really good playbook via blog that Katie wrote on the redetermination, as along with the checklist that you guys created. So with your permission, I'd like to offer that up to anyone that wants it. I'll send it out to everyone. We'll put up a poll. Anyone just says yes, we'll send it out. They're just PDFs, so that you have an opportunity to capture everything just Katie said and more in that playbook, and then have the checklist at your fingertips. I want to bring us back to Columbus, Ohio, and healthy neighborhoods, healthy families. Nick Jones, who leads that program. Nick, by the way, those of you who don't know, is a University of Michigan alum. He's got a big basketball game this evening. If you're from Villanova, please, we're not going to take your questions. But why don't you put your professor hat? I'm going to make you a professor at University of Michigan. Everyone here is in your class. And if you could help, if people wanted to create or co-create with a provider partner a program like this in their neighborhood, in their market, what are some of the things they should be thinking about to execute a similar program to healthy neighborhoods, healthy families?
Great, thank you, and go blue. So yeah, I think Nationwide Children's Hospital plays the role of an anchor institution in these community investments and partnerships that we're involved in. And I think a lot of other health care institutions like ours are situated in communities and neighborhoods that, have historically been either underinvested in or disinvested from. And so I think first and foremost for that, your plan certainly has to be supported at the board or executive level. If not, it's going to kind of be piecemeal in what the program has to offer, and won't maybe combine the holistic institutional type of investment that is needed to drive really community level change. I think secondly, you have to have an internal financing mechanism that can leverage external funding and philanthropic support, especially if you're a nonprofit healthcare institution. So for us, that's our ACO Partners for Kids that invests back some of their savings from their work into our general community wellness work that includes our Healthy Neighborhoods, Healthy Families initiative. Third, staffing, time, and talent. We have a pretty large team focused on this work, but we also bring in our 15,000 employee network organization to support a variety of our efforts, whether it's our mentoring program that has over 250 employees who are working with local schools and youth serving organizations, or a free tax preparation program that recruits employees to serve as volunteer income tax assistants out there in the community to maximize utilization of the earned income tax credit. But fourth and most importantly is that your work has to be one, community informed. So the community needs to understand your work, your business, even outside of just general community work. They need to understand and know what's going on before anyone else does. But secondly, and most importantly, your work needs to be community driven. And by that, you as the hospital have to be at the table as equals with the community to really guide this work. And so we engaged a third-party facilitator to really help us with this, where we had our senior leadership sitting across the table from community members or next to community members to really drive what our investments in the areas of affordable housing, economic development, education, wellness, and community enrichment would look like. If we're not at the table as equals, that is going to be a hospital-driven type of initiative, and it's not really going to address what is most important to the community and what the community wants to see. While we may think certain things are most important, that may not be top of mind. And so coming together with the community and co-designing that work is going to be critical, not just for the start, but for the sustainability of the work.
Wow. If your undergraduate students perform as well tonight as you just did there, that was great. That was a really good list. I really appreciate it. As far as community-based care goes, from a payer perspective, RJ, I know Aetna takes the approach of dividing the community into health zones to better hone in and take sort of an analogous approach to what's going on at Nationwide. Could you give us an overview of how Aetna is approaching health zones and community-based care?
Yeah, sure. I mean, that was a fantastic setup. So the CVS Health Zone program, we're using all of the data, all of the analytics we talk about to identify areas that are lacking in both health outcomes and access to healthcare and in social outcomes, right? So perfect example, actually, it's the zip code that's adjacent to where I live here in Atlanta, the 30318 zip code, which is predominantly Black. The majority of residents actually are over 60, has a much lower life expectancy than zip codes adjacent right to it. And it's really about providing that better care, providing better access. So it's a collaboration. Everything we've been talking about, collaboration with multiple community partners. So I'll kind of maybe list them out a little bit. It's first the Good Samaritan Health Center, which is the local neighborhood health center there. The Atlanta Community Food Bank, Project Open Hand, which is medically tailored meals here in Atlanta. Organization that I've actually worked with is a fantastic organization called the Thanks Mom and Dad Fund for enhancing the support system for seniors. That's just a few of them. Those are some of the bigger ones. But so a great example of what's being done for a health zone to really bring in the social determinants work is that we're taking the bringing on-site healthcare to a senior complex, right? So the senior complex has a nurse practitioner regularly visiting from the Good Samaritan Health Center a couple days a week to do the vital checks, to do kind of early primary care right there, vital signs, blood sugars, doing flu shots, COVID vaccines right there, right where they live, right? Because we know there's mobility issues, we know there's difficult for access. And so in addition to that, then it kind of creates that bridge right back to the community health center. So that nurse is obviously able to set them up, get them a higher level of care. And the big kicker, which made a bunch of news that a lot of people hooked onto, was that there is a partnership with Uber Health as well. So for those residents or to access these services and primary care visits within that health zone, we are offering Uber Health rides to tackle that transportation issue that we know is prevalent in that neighborhood. So there's several health zones around the country that are up and running right now, kicking it right back to Columbus, our favorite city today. Columbus is one of them, and then there's a few others and a few others getting started. So we have Atlanta, Columbus, what I mentioned, Fresno, Hartford, where the traditional Aetna base was, and then or is, I should say, and then Phoenix, Arizona, with a couple more coming online soon that we'll make some fun announcements with here shortly.
That's right. And somehow we've miraculously ended with a few minutes to take some more questions from the audience. I know, Merrill, we were talking prior to the show, and one of the questions we wanted to take off the top, and I can't find it now. If you have it, you could actually take over moderator and ask it. I do have another one I could ask if you want.
Either way, I think one of the questions was, if you want to go with this one or the one that you've selected too, is how, MCOs, how health plans really go about creating housing solutions and the process for it. But if you had another one.
You could go with that. I know, and Amy had to leave about 2 minutes ago. Senior Director of Housing at CareSource. It was in her contract. She had to leave at 55 minutes. She had to tell me that. But yeah, why don't you take that, Merrill, and see if we could give an overview in the next 2 minutes that we have here. That's a great question.
Yeah, and I think, all the health plans really look to solve for housing solutions. We know that people experiencing, housing instability and homelessness can't focus, right, on addressing their health care, right? We have to help people prioritize on those things that are not only important for them, but important to them. Clearly, having a roof over your head and a stable roof over your head is important. And so we go about it like others do, helping, to connect people. We have a landlord engagement program where we work with landlords directly, supporting them, right, in terms of helping to maintain stability for their tenants, right? We work with flex funds, medical respite programs. So constantly trying to help fill the gap. We know Medicaid plans can't pay for room and board, but it doesn't mean we can't help. And so that's how we go about doing it, finding these creative ways to help close the gaps. And that's what this conversation has really been about, and addressing those drivers of health. So a little bit of a high level since we have just a few minutes, but.
That's perfect. I really appreciate everyone taking the time to log in. If you're listening on the podcast, thank you for taking the time to listen to the show. Like I said earlier, we value your time. We hope you take the time, if you've been listening live, to fill out that feedback form that is now in your inbox. Sadly, I will be emailing you multiple times if you don't complete it. So I know you've received enough emails from me already. So we ask you the favor of just a couple of minutes of your feedback. So appreciate it. And to our panel who's taken so much time to prepare with me and to be here today, really appreciate everyone's participation very much. We like to say that to all of you listening that this is your podcast, and we like to call it Bright Spots in Healthcare. Have a good day, everyone. Thank you.
Thank you.